We're going to be discussing decriminalising abortion in Scotland and reproductive rights. We've got some brilliant speakers lined up. We're going to hear from our Executive Director, Catherine Murphy, who's going to chat in more detail about our campaign and where we're at, what we're doing so far, and how we see the campaign moving in the future. We'll also hear from Dr. Rebecca Mason, Research and Policy Lead at the Young Women's Movement, and then we'll hear from Dania Thomas, Director of Ubuntu Women's Shelter. If you have any questions throughout, please pop them in the chat and I'll gather them up for our panel discussion at the end. It'd be really great to hear from you. So any questions, thoughts, please, go ahead and share them. That's enough from me. I'm going to pass over to Kat now. And Max, if you're ready to share Kat's slides, that would be great.
Hi everybody, welcome back. And you've got me again. I'm going to just walk us through some of the work that we've done in the last year on abortion and just some general overview points. Thank you so much to Rebecca and Dania for making the time to join us today. Really, really appreciate it, particularly over the weekend, giving us your time. And also, I should say that on this report, this specific report that I'm going to be speaking about that we published earlier this year on abortion law, I shouldn't take any credit for that report. That report was written by Jill Wood on our team, who is on leave and not able to be here today, hence why you have me speaking to you. But Jill did a huge amount of work on this report this year, and it's been really impactful, and we hope in the next year or so even more so. So Max, if you can move the slide on for me, that would be fab. Thank you. Just to give you a bit of an overview of kind of recent developments on abortion in Scotland and where we kind of are in a legal and policy sense. So I'm sure many of you will know this, but in 2016, abortion law was devolved to the Scottish Parliament. It had previously sat entirely at the UK level in terms of making new laws around the Abortion Act, etc. We published a report in 2016 arguing for a Scottish approach. And also we argued for critical improvements in service provision. So in that report, we raised issues around the weaknesses in access to later term abortions in Scotland, which continues to be an issue, and I'll mention that a bit more. The postcode lottery that appears to exist in Scotland to this day around later term abortions. And the fact that many women in 2016 were travelling to England, a situation, unfortunately, that has not improved. We also argued in that report for improvement in information standards, a consistency in approach to gestational limits across Scotland. Women were receiving conflicting reports around gestational limits. Improved access to long-acting reversible contraception, or LARC as it is known. And we also argued in that for the need to develop nurse and midwife-led services and not just be overly reliant on doctors. We also recognised that we don't have an enormously good understanding in Scotland of how intersectionality plays out in access to abortion and reproductive rights. We suspect that it is not, we know that there's data collected around deprivation and its impact, but we don't know enough about the impact on marginalised or minoritised women in particular. We followed this up in 2018 with a further report on the specific barriers that disabled women in Scotland experience around accessing abortion and reproductive health care. So in 2020, because of the pandemic, we saw a really big step forward in terms of access to telemedical abortion. There had been partial access to telemedical abortion, and what that means is abortion pills essentially that you take at home. So in 2017, it was partially made available. The women could take one tablet at home, but not the second tablet, or not in fact, they could take the second one at home, but they couldn't take the first one, and they had to go to a clinic for that. But because of the COVID pandemic, Scottish Government and the UK Government opened up full access to medical abortion at home, and that happened in 2020. It's been subsequently evaluated and made expanded and made almost permanent, essentially, by Scottish ministers. In 2020, we also saw the launch of the first women's health plan that has abortion as a priority area. And it has a number of goals and targets around telemedical or medical abortion at home access, data collection in line with, the arguments we made in our 2016 report, improving intersectional data collection to understand what are the specific issues of disabled women, of women of colour, migrant women, etc. And then the Women's Health Plan also made recommendations around addressing increasing harassment at clinics and access to long-acting reversible contraception in Scotland. So this, in 2024, in September, we saw a major step forward in terms of the introduction of the Safe Access Zones bill around clinics, or buffer zones as it's colloquially known, to protect people accessing abortion clinics from harassment outside. And that came into force in September, and that was a couple of years in the making, with different partners campaigning on that to huge success, and with parliamentary gaining quite considerable unanimous support through Parliament, not unanimous, but quite considerable support through Parliament, or support. Moving on to the next slide. So just to give you a quick feel for the current picture. So the Buffer Zones Bill is the only legislative change we've seen since 2016 in Scotland. The telemedical advances in abortion pills was achieved through regulatory change by ministers. And it's been really impactful. In 2023, nearly 60% of abortions were undertaken entirely at home. This was compared to 36 in 2020, and less than 17 occur solely in hospital and clinics in Scotland now. We have seen an increase in access to abortion, quite a significant increase in Scotland. So it has risen from around 14,000 in 2020 and 2021 to over 16,000 in 2022 and 18,000 in 2023. And those increases have been observed across all age groups and all NHS board areas. There's a number of factors believed to be involved in this, one of which is the cost of living crisis, and also the aftermath impact of the pandemic, one of which is that there are lower rates of prescribing of long-active reversal contraception. That's been prescribed at a much lower rate than it was before the pandemic. So there are a number of factors leading to that rise in abortion access. The gap in abortion rates between women living in the most and least deprived areas of Scotland has continued to widen. Its rates for women in the most deprived areas are double that of women in the least deprived areas, which I think feeds into the view that the cost of living crisis has had a significant impact. And the numbers of women travelling for later term abortion to England has continued to rise, going from 42 in 2021 to 68 in 2023. Next slide, please, Max. Thank you. So we this year, to build on our work that we've done around these things, we decided this year to delve deeper into the law and the impact that abortion law is having in Scotland. Just to kind of answer the question why we thought this was important, abortion law in Scotland is a kind of patchwork of outdated, in some cases stemming from the 17th century laws, in other cases from the 1960s. And because of that, they largely represent historic models of patriarchal control. They still echo those models and are out of step with modern healthcare provision. They also create arbitrary complexity and delays in access to abortion, and stigmatise abortion as being somehow different from health services and somehow not vital healthcare. And in law in Scotland, whilst women have access to abortion, women have no legal right to abortion and do not cannot have an abortion on request in the law. They must meet certain grounds and certain parameters. And the decision ultimately lies with doctors and not with women themselves. Move on to the next slide. So just to touch on the global context, while there have been really major regressions, such as the US and Poland, there have the general trend is towards globally is towards modernising and liberalising abortion laws, and actually Scotland and the UK now lags behind many European countries and other countries around the world, but specifically within Europe, we're beginning to lag behind. The international human rights standards are very, very clear on what constitutes safe, legal, and timely abortion access, and we fall short of that in our current framework. And also, as I previously mentioned, the rise of the far right, evidence that we can't afford to be complacent at any point. And there's always a risk of potential rollbacks if things are not strongly codified in law. And one of the challenges in Scots law is that it's a patchwork of quite vague laws that are outdated. Moving on to the next one. Thanks, Max. So the current framework, so as I said, it is a patchwork, and it's made up of common law. So abortion is a crime under Scots common law. In England, it's garnered under the Offences Against Persons Act. We don't have that, but legal texts make clear that abortion is a crime under Scots common law. There is limited case law around this, but there are historical cases on it. The Abortion Act was introduced UK-wide in 1967. It sets conditions for legal abortions. So two doctors are needed to approve an abortion. It can only occur in specific locations. So it has been expanded to people's homes, but it's not, for example, been expanded. It's only recently been expanded to potentially other places. But there are still quite significant limits on where it can occur, abortion. What the grounds are, there are 4 grounds for abortion in Scotland, and that is dictated by the Abortion Act. As I say, it does not create a legal right. It merely creates a defence for doctors. So if doctors have met these different conditions, then that's the defence for the provision of abortion, which enables access, but it doesn't create any kind of legal right for women. In 1990, the Human Fertilisation and Embryology Bill was passed that introduced a 24-week time limit. In law in Scotland, prior to that, there hadn't been a legal time limit, and it was generally through medical regulations that time limits were determined, not the criminal law. And then the other law that is in play here is a really archaic law that is from 1809, but has its roots in a law from 1690. Well, and for anybody wondering just how ancient that is, that's from before, the 100 years before the last woman was burned at the stake, 1690. And the Concealment of Birth Act criminalises failure to seek assistance during birth if the child then dies or is missing. The historical antecedents of this act was to criminalise women who had children outside wedlock. And there's been analysis of this law that it actually serves no purpose because there's general laws that can address any wrong, genuine wrongdoing. But actually this is a very kind of gendered, misogynistic law that is still on the books from a long time ago, and is still being applied. Just to move on to the next slide. So just in terms of the impact of the criminal law on women, we know that current laws create delays and medically unnecessary and unjustifiable barriers and administrative burdens within the health service. So 2 doctors' signatures, for example, there's no medical reason for that. Women, healthcare providers and those assisting can face investigation and prosecution. And it has a chilling effect on the quality of care, and clinicians tell us that. Despite the best efforts of healthcare providers to ensure that it limits their delivery of healthcare. And from a human rights and equality perspective, criminalisation stigmatises and exceptionalises abortion. Abortion is seen as somehow a different form of healthcare as opposed to all other healthcare, which is not regulated using the criminal law. Abortion is the only aspect of healthcare that's regulated using the criminal law. So decriminalisation is necessary and required under international human rights standards. The UN is very clear on this, the WHO is very clear on this. And reform would align abortion care with standards in the normal standards in all other healthcare. So, for example, healthcare being patient-centred, which is an increasing norm in the NHS and other modernised healthcare systems. Next slide. So one of the reasons we particularly wanted to look at this is we've seen in recent years in England a significant increase in prosecutions against women. This is largely down to the availability of medical abortion online, and women have been prosecuted for not for taking it outside the very strict parameters in which they've been given them. So we've seen quite a significant upsurge, which is of real concern, and medical professionals, medical bodies, etc., have called on the UK government to decriminalise abortion. Next slide, please, Max. So that was a clinician, a Scottish clinician, shared with us her perspective that recent cases in the media have raised suspicions when women present with later pregnancy loss. Instead of clinical staff focusing on care and support for the women, they can be uncertain if they must report a potential crime. If women think staff may report them to the police, they may delay or avoid seeking medical care. So this has real world impact in Scotland as well as in England and Wales. So next slide, please. So just to show you in terms of the prosecution numbers, there have been 67 in the last 10 years in England, which is really concerning. They've been high profile. There's been calls for changes in the law and for prosecutorial guidance from the police to minimise the scope for these prosecutions. In Scotland, we did some work through Freedom of Information to ascertain if there have been prosecutions in Scotland. What we found was there have been at least 11 charges for abortion in the last 20 years, or since 2002, between 2002 and 2023, there were 11 charges brought for abortion-related crimes. That resulted in one conviction under the Abortion Act and one conviction under Concealment of Birth Act. So we know that this is happening. Prosecutions are happening much less in Scotland, but they are happening and they do have the potential to happen. One of the really worrying things that we've seen in England is that women's use of pregnancy or period tracking apps, for example, have been used as evidence in cases in England. So with the rapid changes in the availability of medical abortion and in technology, we really need to strengthen and clarify the law and improve the law, because without that, there is scope that this could happen in Scotland. One of the things that I've seen in my career as well from working in sexual and reproductive rights in other areas is that when there are media cases, at times, if there isn't clarity within the law, it can result in harmful investigations, even if they don't end up in a charge or in a prosecution. Police who aren't clear on what needs to be done can further investigations if complaints are made, and there can be malicious complaints made, for example. Next slide, please. So in terms of shorter term action that we're advocating for, so we've been in conversation with the Crown Office in Scotland to see if there is scope for them to create prosecutorial guidelines to, in effect, create a moratorium on prosecutions and convictions for women in the short term. And we've also been speaking to Police Scotland about what they can do to similar effect to reduce the scope for investigations, charging and prosecutions. Next slide, please. In terms of decriminalisation, what we believe needs to be done is legislative change to remove abortion from the criminal law. So for Scottish Parliament to introduce legislation that would remove abortion or make clear that abortion is not a crime within common law in Scotland and treats abortion as health. and human rights issue, and will regulate abortion like any other medical procedure. Um, the implications would be there'll be no criminal penalties for women, healthcare providers, or those assisting with consent and in a safe environment. Regulation through medical guidelines and professional standards. So abortion would be regulated like all other healthcare through medical guidelines, and the entire architecture that is there to safeguard the provision of healthcare for all other healthcare issues. And examples internationally that you can see that take a similar approach, for example, is Canada, which decriminalised in 1988. There are also a number of states in the US, like Alaska, Colorado, and New Jersey, that have a really progressive human rights-based framework. Next slide, please, Max. In terms of what that would look like, we are calling for repeal or reform of the Abortion Act to remove outdated provisions, so specifically to remove requirements such as the two doctors rule, to ensure medical abortion, access to medical abortion at home in law. We also want to see opening up for midwife-led abortion care. The Abortion Act, because of its necessity for two doctors, means that it's very overly reliant on doctors. And when miscarriage care and a lot of maternity care is provided through midwife and nurse-led, there's no reason why abortion couldn't be. And also, we want to see revision to the grounds for abortion. We would like women to have the right to choose in law, and not be curtailed by specific grounds. And we have called on the Scottish Government to engage in consultation and participation, particularly with diverse groups of women, and to focus on intersectionality in that. And we are also calling for repeal of the Concealment of Birth Act. There are sufficient existing laws that cover any specific issue that might arise around the death of a child in childbirth, and there is absolutely no need for a specific misogynistic law that's now deeply outdated. Next slide. The Scottish Government could go for partial decriminalisation. So that would be decriminalisation of women and pregnant people, and would remove penalties, but would also would retain some potential for criminalisation of third parties, such as specific offences for unsafe or non-consensual abortion. Decriminalisation with gestational time limits is another option. So retain gestational time limits in law, but decriminalise out with those specific limits. Next slide. So we believe, and I won't go into an enormous amount of detail, but that there are sufficient scope within existing frameworks for safe regulation of abortion beyond the criminal law. So there are existing criminal offences. So non-consensual abortion is covered by common law offences like reckless injury and culpable and reckless conduct. Unsafe abortion is governed by laws regulating medical practice and the use of drugs. There are provisions within the law to protect women against violence leading to miscarriage. There is an extensive regulation around medical malpractice, and there's professional standards and guidelines. So we think that this really needs to be considered before the Scottish Government goes straight to a partial decriminalisation approach that retains an exceptionalising abortion in the criminal law, because we would rather abortions treated like all other healthcare. Next slide, please. So just coming to wind up now, in terms of next steps, the Scottish Government announced last year an expert group, or the year before, an expert group, which it has now formed and we sit on. And it's looking at decriminalisation, reform of the wider legal framework, and that expert group will report later this year. We are doing all that we can to encourage ambition and bravery in that group. And we will keep you posted on that. There will be a phase 2 of the Women's Health Plan, which we've advocated for. That's expected to be announced later this year. and formalised. There's need for cross-party buy-in, because obviously we have the Scottish parliamentary elections on the horizon in May, and if there's a change of government, we need both the Women's Health Plan and the recommendations of the expert group to be progressed regardless of who's elected in May 2026. Um, and then just finally, just to say that, we're hopeful that in Scotland people will see and understand the need for this change. A poll in January 2024 showed that 93% of people polled indicated that they supported a woman's right to choose. So we do feel that the general public are further on than politicians sometimes give them credit for on these issues. However, we also are not naive that current polling is suggesting that the Scottish Parliament elections next year could return some parties from the extreme right in Scotland. So we are alive to the potential for distortion and misinformation, etc., on these issues. So we're going to do quite a lot of work this year on how we effectively campaign for this and we work against misinformation and distortion of the issues in the media and on social media. So I think that is me finished. Our report's up online, and if you want any more information, it's on our website, or please feel free to email us. So I will wind up there, Jade. Thank you.
Great. Thank you so much, Kat. That was a brilliant presentation and a huge amount of detail guiding us through, where we've come from, where we are, and where we want to be. Yeah, I see lots of clapping emoji responses. So thanks so much, Kat. If you've got any questions for Kat, please bob them in the chat, and we'll share them at the end in the panel discussion. Really delighted now to pass over to Dr. Rebecca Mason from the Young Women's Movement. Thanks so much again, Rebecca, for joining us. Really looking forward to hearing from you. I'll pass over to you.
No problem at all. I will just get my presentation up. Oh, sorry. We did test this out earlier and it did work, so I'm hoping it'll.
It's always something at the moment though.
Yeah, it's not showing up for some reason in my share screen.
No problem. We can share them this
Do
end.
you mind? Sorry, I don't know why that's happening.
Of course, yeah.
It's
Max, are
not
you
agree
able
with me.
yeah. Max, are you able to share Rebecca's slides? Oh, there we go. She's on it. Thanks, Max.
Well, thank you so much. That's great. Thank you. Appreciate it. Well, morning everyone. My name's Rebecca and I work as the Research and Policy Lead at the Young Women's Movement. And just for those who maybe aren't aware of us, the Young Women's Movement is Scotland's national organisation for young women's leadership and rights. We've actually existed for over 100 years and we were formerly known as YWCA Scotland. That might be more familiar to some of you in the call. And at the Young Women's Movement, we conduct young women-led research to ensure that decision makers have the necessary knowledge and gender disaggregated data to inform actions and recommendations on implementing policies and practices that do affect young women and girls. And our research is very much guided by the young women that we work with across Scotland. And it aims to address intersecting root causes of inequality and discrimination by amplifying women's voices and by working within different communities through doing participatory and peer research. And we work very closely with young women and girls, primarily aged 16 to 30, in all local authority areas in Scotland. And this ensures that our evidence-based research is rooted in their lived experience. And in recent years, we have been doing quite a lot of work around young women's access to healthcare and particularly their reproductive rights. I do want to recognise, in the past couple of years, there has been a lot of progress. Last year, in our 2022 to 2023 Status of Young Women in Scotland research report that specifically looked at access to healthcare, many young women had told us that they were struggling to access abortion services due to the existence of protests outside abortion clinics and hospitals. So we do really hope that the passing of the Safe Access Zones Bill will alleviate this situation. We've also been doing some work with the Women's Health Plan as well, and we think it's really positive that There's been new youth work support set up for young adults aged 13 to 21 from the point of referral through to discharge within abortion services in Chalmers Sexual Health Clinic in NHS Lothian. And we really do hope to see this rolled out, and we will be working with the Women's Health Plan quite closely over the next year or so to ensure that young women across Scotland can have fair access to abortion healthcare. And in our previous healthcare report, I just want to share some experiences from young women, particularly around accessing abortion healthcare. I think it's really important to remember the people behind this kind of service. And some young women expressed hesitancy around asking for abortion support due to other experiences or interactions with healthcare professionals. For example, one young woman told us, "My GP refused to see me about birth control and mental health. This stressed me out, made my mental health worse. If they weren't giving me birth control, I felt like probably wouldn't do anything to help me abort an accidental pregnancy." So we do think it's really important to look at the wider picture around access to healthcare in general and how this might influence young women's access to abortion healthcare. For some young women, abortion is still associated with quite a deep stigma and complex decision making. And we believe that some young women, particularly those from marginalised backgrounds, might feel forced to seek abortion out with, these more formal routes. Other young women discussed negative experiences of healthcare providers when seeking abortion. For example, one young woman said, "I had an abortion when I was a teenager. My nurse continuously made comments about my age and how I got myself here so young. It made what was already a traumatic experience a lot worse." Another young woman told us, "When I was getting an abortion last year, my doctor, who was meant to explain the process to me, made me feel horrible about myself and used abusive language to try and persuade me not to get it." Now, obviously, these are individual experiences and they're not indicative of the wider system, but what we're seeing through our healthcare research is a lot of young women are incredibly affected by an experience that they have. And we do see that when young women have a negative experience with a healthcare professional, they're more likely to share it. And this influences how other young women can perhaps experience or see healthcare. So it's really important to try and destigmatize the process in itself to encourage young women to speak to their healthcare professionals if they're going through, something like an abortion. Next slide, please. And most young women in our healthcare research just simply asked for better access and care around abortion healthcare. Some felt as if they didn't receive the expert care they deserved, while others reflected on a positive healthcare experience and how it could have been improved for them or for other young women seeking an abortion. One young woman told us, "I had an abortion in 2015 and had non-stop bleeding for 8 weeks following the procedure. I called the contact I was given at the ward for over and over and over again, explaining and saying I was worried and experiencing heavy bleeding, and they ignored me. I ended up dropping into my local clinic where I was finally seen. They had left tissue in my uterus and my cervix was left open. I got an infection and it could have resulted in infertility in the future." Other young women explained that they had had positive experiences, but they could have perhaps been improved. One young woman told us, "Accessing an abortion could have been better for me if the need to see 2 doctors was removed and if the possibility for at-home abortions had been an option at the time. Although this experience was more positive than I expected, I felt that it was hindered by attitudes towards my gender and by a lack of a holistic care around abortion." Finally, a young woman told us, "I had an abortion and the doctor that helped me through the process was compassionate and understanding and didn't try to change my mind. Also, whenever I've had my smear test, the nurses have been great." Again, we're here in reference to individual experiences with particular GPs, with particular healthcare professionals. And we think that this indicates a greater need for trauma-informed training across healthcare to ensure that all young women can experience a positive experience when accessing reproductive healthcare in general. And this was noted by Engender in their report. Some young women may feel unable to approach their local GP or service provider. They may not have access to services that meet their needs, or they may encounter other barriers to accessing abortion healthcare. And this needs to be carefully considered within the context of DCRIM going forward. Next slide, please. So just again to echo what Kat has said, our most current Status of Young Women in Scotland research report looks quite generally at human rights in Scotland. And within the survey responses, where we had around 540 responses, So many young women reflected on the global rollback of women's rights and how this is really affecting them in Scotland. One young woman said, I have seen an uptick in anti-abortion rhetoric and protests, which makes me feel that the right to choose is seriously under threat in the UK. Another said, with abortion being banned in America, me and my friends are starting to worry the same rights are going to be taken from us and it's just going to get worse from there. So we believe that it's really important that we're not complacent, that we can't just assume that this issue will never come to our door and that reproductive rights are guaranteed in Scotland and the UK. I think young women are more aware than ever how fragile their reproductive rights are in an increasingly hostile political climate. So we do believe that decriminalisation is key to push back against harmful rhetoric from abroad and online that seeks to remove the right to choose from young women. We don't think abortions should ever sit within the criminal justice system or the legal system for that matter. It should be considered as a healthcare issue. And we don't think that there's any public interest in criminalising women seeking to end an unwanted pregnancy or those who assist women, obviously carefully considered within the context of their consent, as Kat mentioned. So in our recent survey, young women have now, in our previous healthcare survey, there was a lot of focus around the safe access zones as that was going on at the time. There's now a lot of more awareness of the decriminalising campaign. Young women told us abortion, like any other healthcare procedure, must be decriminalised. Another young woman told us telemedicine and over-the-counter services for abortion medication and contraception must be created or improved. We need a public campaign on women's abilities to choose what is best for them at a given time. Ideally, the presence of a chaperone should be upheld and encouraged for any reproductive healthcare procedures or any procedures really, if it is needed to make the patient more at ease. Next slide, please. So just very briefly, what needs to change? We do think that abortion needs to be decriminalised, that there needs to be more telemedicine available across Scotland, at-home abortion, remove the need for two doctors, as has been explained by Kat. We do think that any process of abortion law reform must seek the views of women, girls, and to ensure that such experiences and their perspectives are built into this new system and that services are designed to meet their needs. So there needs to be kind of a dual approach to improving services as they currently stand for abortion. And aside from decriminalising abortion law, there needs to be further improvements to the system to improve women's experiences. So young women have told us that they would like accessible and local support when seeking abortion healthcare. One young woman even said that even just to have someone to sit down with you and have a cup of tea after you've experienced it would have been really helpful. One young woman also told us that when she did ask for a helpline after going through the procedure, she was referred to a bereavement helpline by the clinician, and this really upset her, and she didn't think that it was really relevant to her experience. And we do think that it would be great at some point in the future to have a helpline specifically around abortion rather than referring women or young people to bereavement helplines. There does need to be more trauma-informed training for medical professionals who work in abortion healthcare, particularly for young women, particularly under the age of 20, who they do, I would say, face quite a lot of stigma because of their young age, and they're questioned about this without any knowledge of how perhaps they have become pregnant in the first place. So this is something that we would definitely be pushing for in the next phase of the Women's Health Plan. And then just finally, we do live in a time where there is political upheaval, the rise of the far right across even the UK and Europe, I would say, as well as America. And we just think that we still need to push for a greater societal acknowledgement of women's reproductive freedom and women's right to choose what is best for them. And that, for us, is the most important aspect of this amazing campaign work that's being led by Engender. So thank you so much. It was great to be here, and I'm happy to answer any questions. And please feel free to email me if you have any questions about this as well. Thank you.
Brilliant. Thank you so much, Rebecca. That was a fantastic presentation. Really appreciate you making the time to join us. Definitely chimes with much of what we're campaigning for and much of the content in the report, as you say. Thank you. I'll pass over now to Dania Thomas from Ubuntu's Women's Shelter. Thanks so much, Dania. Over to you.
Thanks. Thank you for your kind invitation. And it's really been an amazing morning. Just listening to the breadth and scope of Engender's work, and congratulations to the team and cat. Right. So I don't have a presentation, and this kind of I really want to really reinforce the report because I think it's such a well timed and a really urgent report, especially given what people have already mentioned around the strong headwinds that come our way from across the Atlantic and uncertainties after the election in Trump. But again, the big thing for us is really the far right emergence, resurgence in the UK. So, we have domestic issues that are quite urgent. And in the context of that, to have an eye on our rights as they stand is extremely important. So I welcome the report. So I particularly welcome the attention paid to intersectionality. So I think that's kind of quite unique to Engender, given the wider context where these things tend to be obscured. And the clear message at every point, at every stage of the report around the lack of visibility of rights of marginalized women, of color and gender, especially transgender men and non-binary and intersex that demographic. So that's very, very welcome. So we incorporated as a charity 6 years ago with the explicit charitable purpose of alleviating poverty by providing short-term temporary accommodation for women with no recourse to public funds. So I'm viewing this report through the lens of the women that we support, and just to kind of the precursor there is the statistically insignificant women that we support. So I've been doing some research for this presentation, and so the kind of the research on migrant women and access to reproductive health services. I mean, it's still from 2018. The research just seems to have dropped. So there is urgent need for more kind of, more research at this intersection. And so I'm going to kind of speak to the need for that and really extend and reinforce the recommendations of the report. So we have so far supported close to 400 women, and in different ways. So some of them through our shelter, and then in wider outreach and our women's groups that run regularly in our office in Glasgow. And so my comments are intended to really surface and bring to the table the lived and living experiences of women accessing reproductive health services in Scotland in general. So we kind of situating and bringing those voices to this gathering. So for this presentation, I've collated comments from the women themselves and from a small report made by our trauma counselor. So we have a trauma-informed service, and her experience in her discussions with the women, especially in relation to abortion and the implication of access or restricted access to reproductive health services. So we hope over the next few years to work with groups like Engender to highlight and visualize these experiences that emerge at the intersection of precarious immigration status, poverty, race, and of course, gender. In particularly, we would like to map the real harm caused by the casual cruelty of austerity choices. So every time migrant women with precarious status present themselves for services, there are choices that have to be made by providers about whether they have the funds to, extend services to migrant women, especially those women subject to the no recourse to public funds condition. And what we find is this is often interpreted, the NRPF condition, acronym, is often interpreted as no recourse to human rights and no recourse to reproductive rights. And so we see this all the time. So this requires kind of advocacy and pushing back. And Scotland, in some respects, or at least in our work, is it's in some respects there is an open door for accessing health services, but it's not consistent across the board. And I would kind of just like to focus on a couple of things which hopefully over the next couple of years we can kind of explore in more detail. So the first thing is that this idea around the abortion law and it being kind of, the idea is to drag it into modernity, kind of away from regressive social norms and patriarchy and those patriarchal kind of constraints on women's bodies. And so very often what we find is that idea of backwardness actually is a stereotype that applies to migrant women. And the assumption is that migrant women don't access these services because they are bound by these regressive social norms, which is not the case. And I really would like to strongly push back against that stereotype. This is an access issue. And there's no doubt in any of the cases that we've dealt with that women really struggle to get access. And that is a structural issue as opposed to them being somehow backward or tied down by religion and other constraints. So that's the first thing. The other thing that in terms of just reinforcing the recommendation for decriminalization and even going further and saying we do need a right to abortion, because when we look at cases of domestic violence in particular, what we find is there is a layering, criminalization reinforces patriarchy. And so what we have is women will avoid accessing abortion because they don't want to lose their accommodation and they will then perpetuate that cycle of violence. So we've seen this repeatedly. So criminalization reinforces patriarchy. We do need to, that's always in the forefront of it. The third thing that I would like to mention is that immigration law itself has, over the years, especially since the hostile environment, and in some cases before that or prior to that, is kind of the reliance on criminal law in order to enforce immigration is actually so when we talk about the specific intersection with access to reproductive health services, the layering over of criminalization in immigration law actually exacerbates and amplifies the impact that women actually, in terms of access. So that's another thing that we often miss out in statistics. So there's this very specific and particular way in which women who are subject to the no recourse to public funds condition struggle to get access. So it's easier just to go ahead and have a child than kind of, access abortion when they need it or when they're choosing to get it. The final thing that I want to mention that again, I think is going to be an issue going forward, in fact, and it's mentioned already. Kat mentioned the cost of living crisis. And the one thing that we're seeing now is austerity and again, the cuts to public funds and the ability of police services, for instance, to investigate domestic violence is that we have. So we've been approached by both the Paisley police and the Glasgow police to actually help women escape violence because they don't have the ability to do it. So again, we are very small and we're not equipped to do that kind of work, but this is the nature of cuts to public funding, which have, again, exacerbate the problem. I'd like to end with again, it's very raw, and I've kept it that way because I think it's important to reflect on that lived experience and these are things that a woman have told me in response to issues when we were supporting them, and also information from our counselor. So yeah, and so this is just a few kind of reflections. So one woman said, "My entire life is drawn by the black ink of so many refusals, rejections, denials. What do the terms freedom from or freedom to mean to me? What do the terms reproductive rights mean to me?" And this other case is this woman, one of our cases that we're still supporting, and this is her kind of story. So she said, "Many years ago, I walked along the Clyde, hoping, praying that I drop the child of my rapist growing in me. I have no address. I slept where I can, and so many beds. Yellow flowers blend into curtains with green trees, blurred. I forget where my child was conceived. I tried to see the GP in the early days. They gave me a form to fill out my address. I said I slept on the street or where I could find a bed. She said, 'Sorry, we can't help without an address.' I asked a friend for help. He refused. It was a sin, he said, to drop a child. It was against God's plan, he said. I will get deported, he said. I decided to carry this pregnancy to term in God's name. My son, Jesus, plays in the park with his friends. We still wait for a decision on our fresh claim." So that's me. Thank you.
Thank you so much, Dania. I really appreciate you sharing that testimony at the end there. And yeah, thank you so much. It's really powerful. And just a reminder, if anyone wants to stay on the call at the end to chat, to decompress, then please do that. We'll be here. Thank you for sharing all that you did. We've heard a lot of testimony, a lot of detail around the law, that changes that are needed. And I think it'd be really good to move now into the panel discussion with our speakers. So if I welcome back Kat and Dania and Rebecca from the Young Women's Movement. If anyone has any questions, please bob them in the chat and we'll bring them up. I suppose to get the ball rolling, I open a question to the full panel of speakers. I wonder, we've talked quite a bit about some of the barriers we're facing in campaigning for full decriminalisation of abortion in Scotland. And I wonder what speakers think are some of those biggest challenges, the biggest barriers we're facing to generate support for this campaign. And you might like to speak, I suppose, to specific public support or otherwise. So open floor. What are some of the biggest barriers we're facing to gathering support for the campaign?
I'm happy to kick off with that. So I think that we need to be honest about the situation we're in. I think sometimes there's a kind of a certain tendency towards Scottish exceptionalism, that we are somehow different from other parts of the world, or that we are different from England, and we are in many ways, but I think a lot of the same things that are playing out all across the world are here and are evident here. I think that there is a certain level of kind of social conservatism within Scottish culture. I think it's very evident in the medical community in some areas, and more evident in certain geographic areas of the country. I think that the public are, as I said in my presentation, I think that the public are generally much further forward than politicians give them credit for in this area. But I think there is a real disconnect between what public opinion, where public opinion is at, and where politicians are prepared to go, and where even clinicians are comfortable going, because I think there is a fear of the media, and there's a fear of the distortion that can occur, and the way that this issue is covered, and the kind of uh, deliberately, for want of a better expression, hysterical at times way that it can be covered, or the very kind of inflammatory or emotive way that it can be covered. And I think politicians, understandably in some degree, are quite scared of that. And I also think the Scottish media has a tendency, if they can, like in the way that they cover these things, they could do so more sensitively potentially. I think that's true of the media all across the UK. So I think that people in the general public are further on this than they're given credit for, and we need the media, the medical community, in some areas of the medical community, and the politicians to catch up basically, and we need to try and stay on top of the debate to give those people the confidence to move forward in the way that we want them to. But that's a challenge. It's difficult. It's not an easy thing to do, unfortunately.
Yeah, definitely. Really agree with that, Kat. And that media sensationalism is definitely an issue that persists. I think all our organisations would definitely agree with that. And yeah, the distance between public opinion and where the public are at on these issues is really far from, yeah, where government are at. Rebecca or Dania, anything you'd want to add to that? Or
Yeah, I would just briefly add to like everything that Kat said. Absolutely agree with everything you've said. It kind of shocked me whenever, our organization started doing some work around the safe access zones, how kind of well funded and coordinated the anti-choice groups are in Scotland and often have quite strong links with groups in America. And I think a lot of their work is done kind of hidden in plain sight. It's very kind of covert. They're not massively public facing, I would say. And that scars me quite a bit as well. It is often done behind the scenes. So I think you're often, when you're working within women's rights, you're kind of fighting that hidden force. And yeah, I think as Kat said, just be very mindful of that as we go ahead in this campaign, because you mightn't see it necessarily in the media or online, but it is very much there and it's very strong. I would say, for example, before I joined the Young Women's Movement, I worked for Scottish Labour in the Research and Policy Unit. And whenever the Safe Access Zones bill was going through Parliament, we were receiving like every single week letters upon letters of coordinated signatures from people within like constituencies for particular MSPs who were basically anti the safe access zone bill passing. And the kind of we sat down and spoke about it as a policy unit, saying the amount of money that's being put into this to actually send this to every single MSP across the Scottish Parliament. It shocked me quite a bit. So I do kind of see something similar happening as we go ahead with decrim, and just to be mindful of that is really important.
very much so, yeah.
I just want to add, I mean, completely agree with what Rebecca and Kat have said. The one thing is that in just looking at it from the position of where we are at, is that it's unclear about who is exercising power here, because especially for us in terms of the Labour government, we had some hope in terms of, pushing back against Rwanda and all of that. But what we've seen is the pushback from people like Elon Musk, reform, so it's kind of who kind of wields power, and who does a campaign have to appeal to in order to get pushed through, and who are you aligning with? And so those are kind of questions that I would love to be a fly on the wall in an Engender meeting, deciding how to put across a campaign like this, and just to kind of recognize the different parts in play and how do you find your way through that minefield. So yeah.
Yeah, very much so. And let's definitely keep collaborating. Dania, for sure, you're welcome to be more than a fly on the wall, I'd say, at any of our meetings. Yeah. I think that's really true about the different threads of this particular campaign, how we approach it, and because it is for many people a contentious issue, and where they are at with it is really important. And then the layeredness of the landscape on top in terms of cuts and intersectionality and and so on. One question that came through to me was around time. How long do we think this change is going to take? I noticed Kirsten put a comment in the chat to say that some of the testimonies that have been shared today were reminiscent of testimonies she heard in the 70s. So, 50 years on, a lot of the personal experience, lived experience is exactly the same in so many ways, as we know. So, yeah, thinking about time, and that's maybe a difficult question, but I open to the floor.
I mean, I can come in again if that's useful. I mean, I think that one of the things we've been saying in our messaging around this is, there has been a window opened up through the expert group. Now, that's not a guarantee that there will be legislation at the end of that, but there has been a window through this expert group, and some of the messaging we are using around that is, like we've waited since the 1960s for this change in law, and this is likely to be a kind of once in a generation opportunity, and therefore we shouldn't be too. We need to be ambitious. We need to do what needs to be done rather than too hesitant. The risk with that is that you then encourage hate. You encourage a real kind of like backlash, and we are living in an age of backlash, and we know that it can be absolutely corrosive, and we've seen it on other issues. So that's what's going to be the difficult negotiation over the coming years. And I think the Scottish parliamentary elections, if there is a change in government, will the next government pick this up and legislate? It's also going to be interesting to see what happens at UK level, because obviously there's been attempts through other mechanisms to decriminalise through in England and Wales. So I think that it'll be interesting to see what happens in England and Wales. So, I mean, I'm hopeful. I think with good headwinds, we could do something in the next couple of years on this. I really do believe that. But we are living in very, very unpredictable times. So that is said with a heavy caveat that we really do need the media, politicians, etc., to get on board with it. And one of the things that Rebecca said made me think of often in the media, the way it's covered is a kind of both sides approach, and it's so often the case on these kind of culture war issues. It's a both sides approach, when actually what you're talking about is a huge majority of people with one view and a very, very vocal minority with another view, but it's presented in this kind of 50-50 distortion. So we're really going to need to push back against that and combat that if we're going to be successful, I think. But I think there is momentum behind this. I think the medical associations, for example, the prosecutions in England, people are generally horrified by it. And I think there is momentum behind this, and hopefully people will have the courage to go forward. But it is difficult, as you say, Dania, with people like Elon Musk rampaging. Nigel Farage has already said things around abortion. It's not going to be necessarily easy or straightforward, but we're up for the fight on it.
Sorry, I'm muted. Very much so, Kat. Yeah, 100%. I mean, Rebecca or Dania, would either of you like to come back just there, or I'll move us on to a new question if not.
I just wanted to add, so the one thing is in terms of the big picture and the big transformation, like once in a lifetime thing, and I think it's really important to focus on that. But just in terms of your own mental health, I think we need to have smaller wins. And there was a really interesting piece by this immigration tribunal judge who basically stepped down after 23 years. And he said, I can't, the law is illegal. I cannot implement it. And that was then reaffirmed by this interesting piece by Stephen Headley, who's been around and he's kind of commented on. And, justifying that if the law has these harmful effects, then there's good reason not to follow it. And so it's kind of being more finer grained and more nuanced about where the wins are and how that's percolating. Because my sense, especially from the Engender report, is that actually the population is swayed on the issue because of work like this. So that in itself is a big win. I think that 93% was really a very positive takeaway from the report. So, yeah, so I think we just live in hope, I guess.
Yeah, thanks, Dania. Moving us on to another question that came in. What impact has COVID had on the provision of reproductive health services? I know it's been mentioned a wee bit, and why isn't more being done at the moment? Would any of our panel like to come back on that?
I mean, I can quickly come back. I think, one of the big things that we've seen is that the access to contraception, long-acting reversible contraception hasn't recovered yet. And I think that is having quite a significant impact on women's experiences. We also have, and Rebecca will speak more about that, but I think the impact of the pandemic has been really significant on younger women. And their access to sexual and reproductive education, for example. And going back to a point that Dania made, I think there's been the pandemic, which I think we're still getting to grips with understanding due to the breadth of impact that's had on people's lives. But also the pandemic came after over a decade of austerity, and then we had a cost of living crisis subsequent to that pandemic. And I think that all of these things have added up to just enormous pressure on women at all ages. And I think, like, going back to the point about the increases in abortion, we've saw that that's consistent across all age groups and all geographic areas. We don't have the breakdowns by intersectional aspects of people's identity, but I would suggest that it's probably true, and particularly the most marginalised women, you would see really pronounced increases, I would imagine. We do know from a deprivation point of view. So I think the impact is that the enormous pressure on women is making the realization of reproductive health more difficult. It's making it more complicated, it's making it more difficult. And I think that the most marginalised women in our society are feeling it the hardest. And I think that that is also true of the pandemic.
Yeah, I would just to come in there, like last year we did a joint report with the Scottish Women's Budget Group around young women's experiences of the cost of living crisis, and this came off the back of their women's survey where women under the age of 30 weren't really engaging with their online work. And it did come up quite a lot by women sharing the fact that they want to have children, but they cannot afford it in the current climate. And they reflected on things like statutory maternity pay, the situations that they find themselves in. They reflected on housing, as has already been mentioned by Kat. You know, a lot of young women under 30 are living in precarious housing situations. Women reflected on perhaps unsafe relationships that they were in and sharing spaces with people. So there's so much that needs to be considered really carefully, particularly around the rise in the rate of abortion. It's not clear. The Women's Health Plan are keen to explore the links between hormonal contraception and the fact that a lot of young women seem to be turning away from this, and perhaps if that is linked to a rise in the rate of abortion. But again, as Kat says, it's across all age groups, so it's not as simple as how maybe it's being perceived in the media that young women are turning away from the pill because they're watching TikTok and they're seeing videos that are putting them off it. We think it's quite complicated and a bit more complex than that. And it's something that we're keen to work on with the Women's Health Plan team over the next year. But I do think, yeah, the cost of living crisis comes off the back of a decade of austerity. So it's like piles upon piles upon piles of policies that kind of are against women. And young women tell us all the time, we don't live in a world really where it's celebrated as having a child. Like, it's a really difficult thing to go through, particularly if you're in a precarious employment situation or a precarious housing situation. So it's not entirely unsurprising that young women are putting off even motherhood into their 30s, and that also needs to be considered within this context as well. Yeah.
Yeah, I think that's such a good point, Rebecca, about the compounding layers of cuts, discrimination, and so on. Yeah, and the long-term effects that continues to have. We've got a wee bit of time, so I'm going to share one more question. Thanks so much for sending this direct to me. So this question, I would like to go back into the support for women and pregnant people who have had abortions. We know that there is a lot of religious groups trying to pick up on this and to persuade women against having an abortion. We've talked about some of the larger financial forces behind that, and I really agree with you, Rebecca, what you're saying about sort of hiding in plain sight often. Yeah. How can we ensure that women and pregnant people have the emotional and practical support they need when they're going through with the procedure? So how can we ensure women and pregnant people have the emotional and practical support they need when they're going through the procedure? Would anyone like to come back on that?
I think Rebecca actually in her presentation shared some practical examples of that young women had made suggestions. I mean,
Yeah.
I would I think that the NHS does an incredible job of delivering healthcare, reproductive healthcare, and particularly abortion in a context that is not optimum. It's not, the law is not as good as it should be. The operating framework, there's a lot of layers of bureaucracy that are totally unnecessary medically that the NHS does a really, really good job to kind of circumnavigate. But I do think that the stigmatization of abortion, the historic stigmatization of abortion as being somehow different to other healthcare, has compromised the provision of care. And I think that a better legal framework would immediately change things insofar as you wouldn't have like arbitrary barriers like two doctors' rules, etc. But those kind of like, let's call them kind of hard changes, like hard legal changes. But I think what we would hope in the longer term as well, as hopefully stigma reduces within the NHS, that you see a better provision of the kind of softer changes, the cultural changes,
Mm.
the and that ultimately lead to less judgmental attitudes like those ones that Rebecca cited in terms of what young women telling
Yeah.
and that there's a more of a comfort zone and that people that are going in and accessing abortion aren't being made to feel like they're asking for something that's out of the ordinary or is in some way has to be very, very carefully managed because there's legal things to consider and that actually that the NHS and also other providers like BPAS, etc., the British Pregnancy Advice, are empowered to just meet women where they are and provide those softer services and improve the internal culture so that people don't have clinicians, for example, or nurse and midwife-led care. They don't. Professionals can just concentrate on supporting women and pregnant people and not be preoccupied by whatever box has to be ticked or whatever legal threshold needs to be met and actually just concentrate on meeting women where they are.
Mm.
Um, yeah, I'll stop there.
Yeah, 100%. Daniel or Rebecca, would you like to come back at all on that one and no pressure to?
Just really briefly, yeah, I think chaperones is a really, really great idea. Like, I grew up in Belfast in Northern Ireland, which didn't have abortion, I think, until like 2019. And I used to volunteer with just that back then. It was walking into a clinic with women because of the presence of people outside. It was a very, very strong anti-choice presence in Northern Ireland. So I think we've come a really long way from that, and it's great to see. But I do still think I do still think we could be doing more to help people throughout the process of not just the point of access or the point of leaving. There should be a more holistic kind of care around women should have someone to speak to safely and confidentiality. All of that is really important. Coming back to the point that Dania said, domestic violence, women might not have a support, network at home. We need to think about all of that with this aspect of healthcare. So yeah, I think chaperones would be a really great thing. And yeah, I think helplines and everything. We could, in an ideal world with unlimited funding, absolutely, but kind
Mm.
of a chaperone would be a great start, I think.
Yeah, yeah, definitely. Thanks, Rebecca. Thank you so much to our panel. Really appreciate your time, particularly Dania and Rebecca joining us today. Yeah, and wonderful presentations. We've covered a lot of ground. If there's any follow-up questions or anyone would like to be put in touch with the speaker, please let us know. Drop us an email, or you can message us here in the chat before you leave. I think that's all from us today. Thanks so much for joining us. It's been wonderful to welcome you. Kat, is there anything you'd like to share before we sign off?
No, just thanks again to Rebecca and Dania.
Yeah.
And we really want to work with you and your organisations going forward on this, understanding, not putting enormous pressure on, particularly Dania, when you're
Yeah.
a small organisation and a huge demand for your support and services. But we do want to keep in contact with you on this. And just to thank everybody for taking the time out their Saturday morning to join us and show support for the organisation. We really appreciate it. The team and I really appreciate it. And thanks to Jade for your expert chairing of this session. So thank you so much, everybody, and enjoy the rest of your weekend. And we will be in touch with you through our newsletter and our social media and other things. But do let us know if you have any follow-up questions on what we discussed today.